everyone, and welcome again to the Musical Innertube. I am Don Rooney.
And I am John Timpane, and today our guest for the second time is Paul A. Offit, MD, the director of the Vaccine Education Center and an attending physician in the Division of Infectious Diseases at Children's Hospital of Philadelphia. Paul has done it all in the realm of vaccines. He has helped develop vaccines himself. He's an internationally recognized expert in the fields of virology and immunology. And Paul, I just think we should begin by just saying it's got to be busy times for you, isn't it?
I don't think I've ever been busier. It's amazing. It's just all come. I think that when scientists are suddenly in demand on television, it's a sign of the apocalypse.
Well, and they really are in demand, but isn't that encouraging in an era when science has been, at least from some vantage points, under attack? Isn't it encouraging that scientists are on the TV all the time suddenly?
No, when we turn to science when we know we need it, and we certainly need it now. We need a technological way out of this mess.
So we're at a very dramatic moment. We have been seeing videos of airplanes landing and trucks moving and hospital doors flung open and people beginning to get the first needles in arms. And when last we talked to you, Paul, what we were talking about was the need for a really big push for public education so that people know what's happening, know what their choices will be, and know what will be available to them and when. And I'm just wondering what you think about that part of what we're seeing now, the rolling out of the vaccine. How is the public education part going?
I think there are promising signs. I mean, there was a poll conducted in September and October of this year by Stat Harris asking the question, would you get a COVID-19 vaccine if offered? And about 50% of people said no. Now, about only 30% of people say no. It's up to 70% that would say yes. And I think now that we know more characteristics about these two vaccines, that they're about 95% effective, they're 95% effective in people over 65, they're almost 100% effective against severe disease, it's across all racial and ethnic backgrounds, that people feel better now about the fact that it works. Now I think what happens is we're going to have to make them feel better about the fact that it's safe. And I think they can feel comforted that it's safe in tens of thousands of people, but that's not tens of millions of people. And I think when tens of millions of people are vaccinated, and you find out hopefully that it doesn't have any serious adverse event, that people will rate this vaccine even more highly.
Do you think, too, that it helps to see on television people very happily getting the needle? Because I know that's something we've really not seen that much before, our live coverage of the first recipients. Do you think that helps at all?
Yeah, yes, I think where it helps, in the pediatric world, I actually don't like it when they show sort of pictures of children getting vaccines, because what ends up happening is you're taking them, you're sort of pinning them down on that crinkly white paper, and then against their will, you're injecting them with a biological agent, and they're screaming. So what I would prefer that they show is just people, happy young children, healthy because they've gotten a vaccine. Here I actually feel differently. I like it when you see these people, you see the needle going into their arm and you see them just sitting there calmly getting it and then smiling afterwards to let you know that this isn't really that big of a deal, that you can handle it.
And isn't that part of the message is that, okay, there's a momentary discomfort, maybe, sometimes not even that. I mean, there's some people who are really good, as you know, you hardly know you've gotten a needle, but still, it's not that big a deal. I mean, it just seems as though that's got to be part of the message somewhere, don't you think?
Yes, I completely agree. And I think we need to be honest here. I mean, for the Pfizer and Moderna mRNA vaccines, there is a rocky sort of effect profile, immune effect. It's hard to call it a side effect because it's just an effect of your immune system where you could get, as your immune system is activated to respond to this protein, this SARS-CoV-2 spike protein, that you can have fever and chills and headaches and muscle aches. I mean, so much so that you might miss a day of work. So it has a little more, it's of a difficult safety profile than a typical, say, pediatric vaccine. It's more like the shingles vaccine, actually, which can do the same thing. But, that's a small price to pay for a vigorous immune response.
Can I ask further in the service of public education? So these are symptoms that don't lead to anything else, though, right? This is a day's sort of discomfort, the body sort of getting used to having this in it, but it's not the disease really itself. Am I correct?
That's right. It's just mRNA. It's just that small piece of genetic material that codes for a protein, in this case, the SARS-CoV-2 spike protein. It enters your cells, the cytoplasm of cells outside the nucleus. It then sort of is made by that cell. The protein is made by that cell. That cell, which is primarily something called a dendritic cell, which is a sort of
Right.
kind of like the orchestrator of your immune system. That cell then travels to the draining lymph node underneath your arm, the arm that got inoculated, and that's why people can get sort of swelling of that lymph node. They're also a good
Yes.
sign that you're having a good immune response. That's right.
So your body is doing what it's supposed to do, which is, I think, to me, what a lot of people don't understand about vaccines is you're not getting injected with a medicine exactly. You're getting injected with something which activates your body to do what your body does best, which I think is a beautiful thing.
No, I think it's great. It is novel. I mean, we haven't really done these so-called genetic vaccines before, so there's going to be the kind of requisite fears that that this gene, this messenger RNA, is going to enter your nucleus, which is not possible. Then integrate itself into DNA, which it can't do, and then
Yeah.
sort of cause you to have I guess X-ray vision or something. But that's not.
Let's talk about this because this is one of the reasons why we have this particular vaccine so incredibly quickly, isn't it? Because we're using RNA. What is it?
Recombinant.
Yes, so it's a small piece of this sort of RNA, which is that's the in your cell. The DNA makes so-called messenger RNA, which is just a small piece of genetic material that then codes for a protein, which is then translated into a protein in the cytoplasm of your cell.
Yeah, this is something that that is revolutionary. You said we're really not doing this. We haven't done this before.
No, this is the first commercial product for an RNA vaccine.
So there are how many different versions of this? I think the one that we're talking about now that's being distributed is the Pfizer version. The company Moderna has made one as well. What are the other versions of it? They're just different companies doing the same thing, basically?
Well, so these will be the two mRNA vaccines. I mean, I'm on the FDA's vaccine advisory panel. We will be meeting tomorrow to discuss this vaccine. Assuming we approve it, then the FDA will presumably listen to our advice and then, recommend or approve the vaccine through emergency use authorization, probably on Friday. And then over the weekend, the CDC will look at the same data independently and probably also approve it so that by the following week, Monday, this vaccine too will start to be shipped. That would be the guess.
What kinds of things happen at a meeting like the one you're going to tomorrow? Is there free discussion? Is it a series of reports? Do you look at PowerPoints? I'm just wondering, can you talk to our listeners about what kind of scene is going to happen tomorrow at that meeting?
Yeah, so we have the agenda. I mean, the way that it works is that first the FDA will present what are the rules for emergency use authorization. Then someone from Stanford is going to talk about what are the ethics of allowing people who are in the Moderna or Pfizer trial who were placebo recipients to now receive vaccine, which would then basically end the trial. Then, the so-called sponsor, in this case Moderna, will present the specifics of their data. In which case, you have like 10 minutes to ask questions. Then there's an open public hearing where, for an hour, you hear the public talk about their concerns, and then the FDA presents kind of their review of these data, and then we have basically 2 hours at the end of the day to ask our questions to the sponsor and to the FDA in terms of what we things that we were concerned about.
That's quite a busy meeting, and and a lot of work to get into a single meeting. You have both the public comment and then your own period of discussion. Is there going to be? Do you think there's going to be parts that are going to be more and less vigorous? Do you think?
The things that will may get hung up a little bit is that there were a few cases now of sort of severe allergic reactions associated with Pfizer's vaccine. Once that was out into the world, I mean, the United Kingdom reported, I think, 3 cases. Now there's one more case. I hear I just got an email from a reporter. So that's the question. Does this vaccine cause severe allergic reactions? It wasn't seen in the trial, and it wasn't seen in Moderna's trial either, but it seems to be happening in the world. And why is that? So I think we need to know that and how to handle that. I mean, right now the CDC does have a recommendation that if you've ever been injected with a medicine and had a severe allergic reaction, you shouldn't get this vaccine. But for everybody else, and that's a lot of people. I mean, tens of millions of people carry EpiPens around with them because they're severely allergic to peanuts or eggs or whatever. So, how about them? And, I think the CDC made the right decision was, you can still get the vaccine, just wait for 30 minutes to make sure there's not a problem. So there's that. And then there was this Bell's palsy issue, which just so Bell's palsy is inflammation of one of the cranial nerves that sort of supplies the musculature of one side of your face.
Right.
So called cranial nerve 7. And when inflamed, you get sort of this drooping of one side of your face. And it can take a while to recover that. And sometimes you don't recover that. Now, that was seen in 4 cases in the vaccine group, but none in the placebo group for Pfizer. Then it was seen in 3 cases in the vaccine group, but only 1 in the placebo group in Moderna. So that's really 7 and 1, which is, possibly and likely to be coincidental, but you don't know that until you're in larger numbers of people. So I'm sure that there's going to be a quick look as millions of people get this vaccine soon to see whether or not there's any evidence that also happens when these vaccines roll out.
That's an interesting issue about when to allow the placebo folks to begin taking the vaccine. I suppose they want to continue the trials. Am I correct?
Yes, and it's when you submit for licensure, you really have to continue the trials, for whatever the pre-specified time was, 6 months, a year, 2 years. The problem with that, though, is that let's suppose that you were an essential healthcare worker, which is likely, actually. I'm sure there were many essential healthcare workers that volunteer for these trials. Now you have a product which clearly is highly effective and appears safe. You are in the 1A tier for getting this vaccine. I think it's not fair to say to that person you have to continue to get placebo when they're continuing to be at risk.
But of course, the people conducting the trial might be a little reluctant to do that since they need the data. It's
not personal. I think you can always opt out. I think that is your option to opt out. If you, of course, you have to find out whether you're a placebo or a vaccine.
When you have more than one product out in the street, some of the conversation is going to be about, well, which one should I get? But my impression from studying these 2 products is that they are largely comparable. Is that misleading, or is that pretty much right?
From the standpoint of safety and effectiveness, that's exactly right. There are some differences. I mean, the mRNA molecules themselves are different. So one dose for one of the companies, Moderna, is 100 micrograms, whereas for Pfizer, it's 30 micrograms. There are different dosing intervals. For the Pfizer vaccine, it's 21 days for the second dose. For Moderna's, it's 28 days. The lipid formulations are different, because these mRNA molecules are encased in this complex lipid nanoparticle that are different between the 2 companies, which is why the storage and handling characteristics are different. Pfizer's has to be maintained at, virtually minus 100 degrees Fahrenheit, which means dry ice, so it's a little more difficult to ship and store.
What are you looking for now, Paul, in terms of the next couple of months as this rollout continues? I mean, do you have some fingers crossed somewhere? Are you looking? Are there some things you really want to know? What do you think?
Well, Maurice Hilleman, who I consider to be the father of modern vaccines, he did either the primary research or development on 9 of the 14 vaccines that we give to infants and young children, said it best. He said, quote, "I never breathe a sigh of relief until the first 3 million doses are out there." I feel the same way about this. You have to be humble here. This is a novel virus, this SARS-CoV-2 virus. It's already caused a number of clinical and pathological changes one would have never predicted. And you're now meeting that with a vaccine strategy, messenger RNA, with no commercial experience. So you have to be humble, open-minded to the fact that there may be something that you haven't thought about. But I think once several million doses are out there, we'll know that.
Let's backtrack a little bit too, because you mentioned before there are 2 doses that are needed, or 2 applications that are needed for this. Why is that? And what does the second dose do that the first one didn't?
Right, so the first one sort of primes the immune system to start making those SARS-CoV-2 antibodies, and the second dose really boosts it, so you get an even more dramatic response. Sometimes you can get away with a single dose. I know Johnson & Johnson's product, which is not a messenger RNA vaccine, looks to be a single dose vaccine. some live attenuated viral vaccines or single dose vaccines. So we'll see. But certainly in the sort of so-called phase 1 trials, the so-called dose ranging trials, they found that they got the immune response, meaning virus-specific neutralizing antibodies, that compared most favorably to those induced by people, who had naturally been infected with this virus. It was most favorable after that second dose.
Is this going to be the beginning of the end of the pandemic, as most people are hoping? How long are we going to continue to go through the phase of social distancing and masking and all that before the vaccination sort of kicks in and starts being the thing that takes over?
I think this is the beginning of the end. I think there are several things that are going to be coming in the next few months that will work against this virus. Number one, the vaccine. That as more and more people get the vaccine, that means more and more people are less likely to get infected and to infect others. Two, you do have an administration coming in which takes science seriously, which is going to do everything I think it can to promote the hygienic measures like masking and physical distancing and hand washing that are a potent way of actually stopping the spread. And as you move into the warmer months, this virus, as you see even over the summer here, it's came down as compared to when it's cooler and drier and less humid. That those conditions, i.e., winter conditions, usually favor the spread. So I think all of those things are working against the virus. But again, I think right up until Christmas, probably through January, maybe into February, it's going to be rough. But I think you're going to then start to see a decrease in the number of cases, decrease in the number of hospitalizations, decrease in the number of deaths, decrease in the percentage of people who, when they're tested, find that they're positive, and we'll be on our way to dramatically reducing the incidence of this disease. And then what will happen, I predict, is we're just going to have to decide at what level of cases and hospitalizations and deaths we're willing to say, okay, I can go back and lead the life I was leading before.
Is there an algorithm or a way of determining that? I'm sure people have written about this, but obviously this is a public health decision and an organizational decision as well as personal decisions. But how do we figure out when we hit that sweet spot, Paul?
Yeah, I don't know. I mean, so for example, this past year, there were about 400,000 cases of flu hospitalizations and about 20,000 deaths. The year before that, there were 700,000 flu hospitalizations and 60,000 deaths. Every year, we say we can live with that. Now, truth be told, if we were willing to mask and social distance every winter, we could dramatically reduce those numbers. But we say we can live with that. I mean, I'm a Philadelphia Eagles season ticket holder. When I go to games, I would be much better served wearing a mask among these 67,000 people. But as John Timpane well knows, it's very hard to boo through a mask.
Yes, I do know that. Actually, I think I would wear a mask if I went to an Eagles game right now. I'd try to hide the fact that I was even there. I'm only kidding. And by the way, my condolences about how the Eagles are doing, Paul. I root for them too. It's difficult enough with the pandemic.
So, Paul, the vaccine right now is going to healthcare workers and other frontline workers. How soon do you think it's going to get dispersed to the general public?
Well, I know Moncef Slaoui, who's the head of Operation Warp Speed, said he thought that could be March. Dr. Fauci said April. I think both of those are really aspirational. I mean, you have to, if just the first group, the first tier, the so-called 1A tier, are people who live and work in long-term health facilities, as well as essential workers, i.e. healthcare workers, essential healthcare workers. That's 24 million people. When you get to the tier 2, which is other essential workers, transportation, education, utilities, law enforcement, grocery stores, pharmacies, et cetera, that's about another 85 million people. So now you're already over 100 million people. Then you still haven't gotten to the general public yet. Now you go to tier 3, which are people greater than 65, which are about 50 million people. And then anybody who has a high risk medical condition like obesity, which is roughly 30% of the U.S. population, and diabetes and chronic lung or heart disease. So you're really talking about 150 million people, half the adult American population, before you get to then everybody else. It's a 2-dose vaccine. That's 300 million doses. Right now, I don't even think we have 40 million doses that we're distributing. And, it's not that easy to mass produce a vaccine. The old joke is, the hardest part of making a vaccine is making a vaccine. And here you have this, it's not the mRNA that worries me, because that's a synthetic product, but that complex lipid nanoparticle has never been scaled up before. And am hopeful, fingers crossed, that there's no hang-ups with clumping and all the many things that can go wrong when you try and make this kind of lipid nanoparticle, and that everything goes smoothly and we can make 10 to 20 million doses a week. That would be great. But I think that's aspirational. So if you're asking me when do I think it's going to be the general population, I'm going to guess early summer.
And what's the easiest way to get people in to get this vaccine, do you think? Because I've seen all sorts of different proposals, some of them along the lines of like a military push to try to get people aware of the vaccine and get them to come in to take it. What do you think happens there?
I think it's just going to depend where you are. So for example, in my state, Commonwealth, Pennsylvania, you have the two big cities on the east and west, Philadelphia and Pittsburgh. There's plenty of sort of facilities around that can easily handle this Pfizer vaccine, which,
Right.
has to be constantly maintained on dry ice, which, doesn't grow on trees. It's not easy to do that. But then you go to sort of the rural, sparsely populated areas of the Commonwealth where, there might not even be a retail pharmacy nearby. And I know that Rachel Levine, who's Secretary of Health in our Commonwealth, has talked about having like essentially drive-through clinics, and maybe the same way that you would have, say, a testing clinic that gives vaccines that are attentive to all the needs that you're going to have for this kind of vaccine. I think it's going to be a real challenge. I think making this vaccine was really hard. I think getting it out there may be even harder.
I know that people have been talking a lot about the last mile logistically, right? What happens? You can get it. You can get large amounts of vaccine to hubs, but then the next distribution arm might be a little bit challenged, especially in states and commonwealths like Pennsylvania, where there's a lot of rural areas that are very rural, very hard of access.
Definitely, I think this is going to be the hardest part. I'm just watching it play out in my hospital, and the person who's the head of this for our hospital is excellent. And he's very clear who's getting which vaccines when, and people are signing up for it, and they're getting it. And, our pharmacy obviously has all the facilities that they need to make sure that Pfizer's vaccine can be stored adequately. But, I just think it's not going to play out so easily elsewhere. By the way, I'm not at the top of the list, even though I'm on service next week and we do have a COVID board. I will be rounding in that board. I am not one of the first people to get this vaccine. Come on, man. You know anybody in my hospital you could help me out with on this?
We'll put in a good word for you.
Yeah.
I don't know how much that'll help. When we're talking about distribution, if it gets to a hub and then it has to get from there out to people, I know I've heard that CVS and some of the other pharmacies are getting involved in it. I'm sure doctors' offices will be involved in distributing it as well. Is that correct?
It depends on whether they can really maintain in dry ice. You constantly have to be putting dry ice in that receptacle. And then once thawed, you have 5 days in the refrigerator. And then once reconstituted, because it comes in this 5-dose concentrated vial where you have to reconstitute it. Then you have about 6 hours. So you have to give those 5 doses in 6 hours, which means you have to line people up. You can't just have 1 or 2 people in the waiting room waiting to get the vaccine. You have to have many people in order to not throw away product.
Goodness, that is the ultimate in inventory liquidity. That's such a challenge to think about. I want to ask a question about the way things have gone the last month or so. It seems like things have really accelerated, and glory be, we see the first vaccines here, and it is before Christmas. So there's a sense, at least in this, chapter, that government, which seems not to have done so well earlier, is doing a little better. I don't want to talk about politics so much, Paul, but is that your sense too? That it seems like, there's been more coordination and better coordination?
I think when we look back on this year, 2020, 10 years from now, I think we'll be struck by 2 things. One is that no one would have predicted, not a scientist on the face of this earth would have predicted that in January 2020, when Science magazine published the sequence of this virus, SARS-CoV-2, and now we knew the sequence that coded for that SARS-CoV-2 spike protein, which is the key protein.
Yes.
That then within 11 months, we would have, using a novel technology, messenger RNA, have completed 2 large clinical trials of 30,000 and 44,000 people that showed that this product was 95% effective and safe. No one would have guessed that. On the other hand, the other powerful means we have to bring this virus to its knees is masking and social distancing and personal protective equipment and taking care of our hospital personnel who are on the front lines, which we were terrible at. So we got the high tech stuff, the harder stuff right, and just couldn't really do the low tech stuff right, which is just ironic.
So that is both. I'm of course I am a godlike figure, so I can sit on high and say these things. But that's not just government we're talking about. That's Mr. and Mrs. America. I mean, that's people on the street. That's the choices that folks made on the ground, also, isn't it?
Yes, that's so true. It is this sort of culture, this country that was founded on the basis of individual rights and freedoms, including religious freedoms, which means that we have the amazing capacity to claim freedoms that we really don't have. So,
Yeah.
for example, like it's not your freedom to catch and transmit a potentially fatal infection. People rip off their masks and talk about how this is my freedom. No, it's not. It's just really, frankly, upsetting.
And when I look at our frontier sort of ethic, such as it is, it has stood us in good stead, certainly in a lot of different ways, obviously, but it could have been mitigated, I suppose, by more of a push by the people who really did know. In other words, it didn't need to be politicized quite so much as it was. You know what I'm saying?
Yes, no, I agree. I suddenly how this virus became a political entity is remarkable. We were usually good when we're attacked by a foreign invader. In this case, a virus. I mean, when we were attacked in 9/11, we all pulled together. I mean, everybody stood behind the New York City Fire Department and police department. We all saw that as a shared national tragedy, much as we saw polio as a shared national tragedy. This we don't see that way, which is odd to me.
Um, I have no knowledge of the way that it's gone in other countries. Has there been a degree of politicization elsewhere? Do you know anything about that, Paul?
Yes, supposedly we're not the only group place that does that. Yes, there has been politicization elsewhere in Europe. Yes.
So there has been resistance by folks on the street, or at least sort of maybe fear, maybe just not wanting to wear masks, people wanting to get back to social life, that kind of thing.
Either just sort of pandemic fatigue, or the
Yes.
willingness to buy into this kind of cult of denialism that I'm not going to believe what's right in front of me.
We heard about the vaccine being distributed in Britain. Is it being distributed anywhere else besides Britain and the United States? Have any of the European countries started vaccinating?
Not that I've heard, but it'll be interesting to sort of compare what happens in Britain versus the U.S. just because they have a national health system. So you would predict that they would have an easier time, more efficiently getting the vaccine out there. But we'll see.
They're not doing vaccination in China yet.
They're sort of a black box. I mean, supposedly hundreds of thousands of people have received that Sinopharm vaccine, which is a whole killed viral vaccine in a manner similar to, say, the polio vaccine or the hepatitis A vaccine or the rabies vaccine. But you just don't see those data. Obviously, they have a lot of data in terms of effectiveness and safety, but you haven't seen those data published yet. I haven't.
And the British version of the vaccine was developed, I want to say locally, but it was developed in Britain, right? I understand Oxford, I guess, University had something to do with putting it together.
No, so the vaccine that's currently being used in the United Kingdom is Pfizer's vaccine.
Was there one that was being developed in England with the cooperation of one of the universities?
Yeah, so the Jenner Institute, which is part of the University of Oxford, has their so-called replication defective simian adenovirus vaccine that's being worked on in collaboration with AstraZeneca. They've done a lot of sort of slipping and falling. So I don't. They're in the midst of a phase 3 trial, but have stumbled. So I don't think we're going to be seeing that vaccine for a while.
Is there going to be a survival of the fittest when all of the vaccines come out from all of the different companies?
Not sure. I mean, if you look at influenza, for example, there are a number of companies that make influenza vaccine using different strategies. I mean, there's the normal sort of influenza vaccine. Then there's high dose influenza vaccine. There's squalene adjuvanted influenza vaccine. There's so-called flu block, which is a recombinant DNA vaccine that only makes one of the influenza proteins. So there's sort of at least 4 different strategies, and intranasal, which is a live attenuated viral vaccine. There's just 5 different vaccine strategies for an influenza vaccine. And when I walk into the pharmacy and get an influenza vaccine, I have a choice as in terms of which ones I want to get.
One thing that you said made me think that maybe a really good habit for Americans to adopt is thinking about wearing masks in public during flu season every year. And why not? It might help, and it's not that bad.
I think you'll see a proof. I think you're about to see a proof of that. I mean, it's December. Watch what happens. December, January, February. You will be able to compare flu hospitalizations and deaths this year with last year and the year before. And if what happened in Australia, what happened in South America, which usually experience their flu seasons before us, happens here, we're going to see a dramatic decrease in flu because we're masking and social distancing. But I don't know whether we'll learn that lesson. I don't know. I mean, it's hard to get people to wear masks now when you have a virus that's circulating and killing people.
About the severity, we had the bird flu, we had the swine flu, we had SARS, now we have this. Each progressive virus seems to be worse and a lot harder to contain. Is that just me thinking that, or is that actually happening?
No, I think, MERS and SARS had a reasonably high mortality rate, as did the H5N1 virus. It just never spread, really, and to this extent, because this virus could be shed and spread asymptomatically. So now anybody you run into on the street or in a department store or whatever could be infected, either an asymptomatic infection or pre-symptomatic in their disease, and be, and kill you. So now anybody you see on the street could kill you. And I think that's really the surprise here with say SARS-1 and MERS. When those viruses cause disease, it was invariably moderate to severe disease. So you sort of knew who was infected, so you could put a moat around them and quarantine them and stop spread, which is what happened. Here, it's like anybody could be carrying and shedding this virus, which was its particular horror of this virus.
I hate to sound like a schoolmarm, but Paul, what did we learn from all this?
From this past year?
Yes, from the past year and the scramble to get the vaccine together, and the fact that we just weren't ready for this pandemic. Are we going to be ready for the next one?
You would have to believe so. I mean, how much more information do we need that what can happen in one country can affect the rest of the world? That in 2002 is when SARS-CoV-1 raised its head. 10 years later, MERS raised its head. Now we have really within 20 years now the third novel coronavirus with pandemic potential, except this one was spread easily by asymptomatic infection, which no one really would have predicted. And so we when H5N1 raised its head, the H5N1 bird flu raised its head like in 2005, there was put in place a pandemic plan, which Dr. Fauci was heavily involved in. The current administration just didn't follow that plan. They weren't interested in that plan. Now, because this virus brought us to our knees, crushed this country, joblessness, homelessness, food insecurity. I think I'd like to believe if we haven't learned our lesson with this, we'll never learn it. And from now on, I'd like to think that we'll have a plan in place, mostly for international surveillance, so that when these viruses raise their head, that we spring into action, which didn't happen here.
Dr. Paul Offit, thank you so much. I know that you are running around like a coronavirus with its spikes cut off, and I just want to thank you for being so generous once again as we touch base during one of the most dramatic moments, really, in public health history. Thank you.
Thank you. It was fun.
And as always, thanks to you for listening to the Musical Innertube. If you'd like to get in touch with us, the email address is musicalinnertube, all one word, @gmail.com. On Twitter, John is @JTimPayne, Don is @DonRooney9, and our webpage is musicalinnertube. That's musical spelled with 2 A's, .libsyn, spelled LIBSYN.com. We're available on Amazon Music. If you're a member of Amazon Prime or are subscribed to Amazon Music, just type Musical Innertube in the search box to find us. We're also available on Facebook, YouTube, Apple Podcasts, Stitcher, Spotify, SoundCloud, iHeartRadio Podcasts. Like us and give us a good review on any of those platforms. And did you ever wonder why we sing at Christmas? Could it be because Santa's sleigh at one point was trapped in a big, huge block of ice? You'll get the entire story if you go over to musicalinnertubeplayers.libsyn.com. That's musicalinnertubeplayers, all one word, .libsyn, Libsyn.com, and click on A Christmas Carol. And as always, thanks to virtual band Car Radio Dog for our theme music.